So after a big talk provided by Arun, I will share some very simple message regarding the invasive fungal disease due to Fusarium. I know the majority of you are not infection control personnel. So you may take time to Google Fusarium outbreak Mexican. Okay, I just, as a physician, I share 3 cases and talking about the diagnosis, therapeutic challenge, and something. Okay, this is the first case we report many years ago. This gentleman have fever, myalgia. I highlight in red means the very unique feature for Fusarium. And generalized erythematous papule on day 8 after stem cell transplantation for severe aplastic anemia. The histopathology of the skin revealed mycotic embolism. Culture of the blood tissue from skin biopsy grew Fusarium solani. Now we call Fusarium solani species complex. Despite the conventional amphotericin B therapy, fever persistent, graft failure. Despite the second transplantation, no recovery of the marrow and pass away. This is our bad experience. The second experience, because we had experience, so this gentleman, he received anti-CD52 monoclonal antibody. It's a salvage therapy for refractory cutaneous T-cell lymphoma with leukemia transformation. The underlying disease getting better, but become neutropenic, and he had fever and numerous skin lesions. He also complained of odynophagia. Open his mouth, you can see the mushroom-like lesion. The blood culture, the skin, the oral lesion, all grew Fusarium solani. As we also do the MIC. Its MIC is for AMPHO, for VORI is high. So we give the high, from conventional AMPHO, we switch to liposome. We give the voriconazole, high dose, guided by TDM. And this gentleman survived. So this is a good experience, just because of the previous experience. The third case, unpublished one, another gentleman with a mixed phenotypic acute leukemia, relapsed and refractory. He received posaconazole during the induction chemotherapy. He received micafungin for BMT, very high-risk transplantation. And the disease status remained very poor, prolonged neutropenia. He received venetoclax and azacitidine. Okay, a series I'm not familiar with, but one day in May, he complained nasal congestion and cough, and the image shows sinusitis. Though serum galactomannan antigen was negative, we start voriconazole under the impression of possible invasive fungal, mold infection, and from May. And that discontinued in September just because of breakthrough candidemia due to other reasons, Candida tropicalis. When 1 month later, he was admitted for pre-BMT evaluation, and the follow-up, the image showed clearance of the sinus. We also do the nasal swab, and we got the preliminary report that there's a mold isolated from the nasal swab. At the same time, he became fever. There's no respiratory symptom. And at that time, he had antibacterial, continuing micafungin and flucytosine. He had breakthrough fever. Okay, what next? Because the nasal swab, we have no idea what is the meaning, the clinical significance of the mold isolated from nasal swab. It is just a surveillance culture before transplantation. So we consult otolaryngologist to do the FACE, and the FACE showed the crust. So our good partner said, we highly suspect this is fungus. So we initiate VORI and the liposomal amphotericin B. And all the nasal swab, blood culture, face culture grew mold. You can see the left panel. This is a culture, And the right panel, this is a skin. This is the biopsy from the face. You can see the adventitia is like structure, the sporulation. So all the information we have presumptive diagnosis as invasive fusariosis. However, fever persists 1 week after combination therapy. We're already very aggressive and continue GCSF. However, still low cell count. And the follow-up blood culture remain positive. So we escalate liposomal amphotericin to 10 milligram per kilo per day. Continue voriconazole titrated dose by the TDM as high as possible, and add on caspofungin. It's triple therapy. And we do the surgical debridement granular infusion. So his condition improved and the neutropenia resolved. So another successful story. Okay, why we concern of Fusarium? This is a global distribution and listed as one of the high priority fungal pathogens by WHO. Fusarium is important from a One Health perspective. You can see from the agriculture side, in human side, in the community, in otherwise healthy adults, it can be causing localized infection in the skin or in the keratitis just due to trauma or contact lens solution contamination, or in the healthcare setting during the outbreak. In addition, it's a concern of drug resistance. The resistance not only limited to those with prior antifungal use, also might relate to agriculture use. Nowadays, as I mentioned, as I shared, the third case is a sequential breakthrough infection. So this study emphasized that you can see the right-hand side. They emphasize the breakthrough infection, half of them are due to the resistant or non-susceptible fungus to prior antifungal use. Okay, according to this study, they showed the shift of the mode distribution following inpatient received azoprophylaxis. Among them, you can see the Fusarium ranked third, and about 13 or 10% among them. Particular concern is due to, although there's only 3 cases, you can see the Vori, Posa, and Ampho. It's a very high MIC. It's non-wild type. I would like to suggest you pay attention to the MIC for Ampho B. This is not achievable by conventional Ampho. This is in the morning section why I emphasize that. If you are aware the resistant or non-wild, non-susceptible to the primary agent, please switch to alternative agent. But Ampho B, we have conventional one, we have liposomal formulation. For this kind of MIC, please do not use a conventional Ampho. Please use the liposomal directly. Compare the Aspergillus versus Fusariosis. We have no experience regarding Aspergillus. Both of them have some similarity, including single-palmy portal entry, the image finding, although the distribution might vary between them. And histopathology is similar, and they have acute branching septate hyphae. The biomarker, Fusarium will cross-react, so might be positive if you test the galactomannan or beta-D-glucan. The outcome poor, and the Fusarium even worse. And there's a hostile reservoir in the air or in the water. But there's some difference or unique feature in patients with Fusariosis. The most important, the blood culture is very commonly positive. However, for patients with invasive aspergillosis, it usually is contaminant, not true, but Fusarium is true. But be very, very careful when the lab they will call you when the signal becomes positive. They will call you that yeast isolate from blood. Just be very careful when you see an immunocompromised host. As I mentioned, multiple skin lesion, and the lab told you the preliminary report is yeast. Be very careful. Wait for several hours. Ask for lab, would you please check the blood culture smear again? It become mold. And the skin is very likely is a skin lesion. Might be the localized lesion due to the trauma. But for immunocompromised, usually multiple skin lesions at different stage of the evolution. At times, sometimes it's painful. It might be a subcutaneous nodule, eczema-like bullous or target lesion surrounded by a erythema. Many of them complain myalgia. The most alarming is the resistance to multiple antifungal agents. This is the distribution of Fusarium, the clinical specimen. You can see the number 1 is skin lesion. The number 2 is blood. The number 3 is tissue. It's totally different from other mold. So this is equal score. I know many of you are familiar with equal score. Equal score for Fusarium, they show that very unique, the blood culture. The second, the skin. Very important, when you can see the skin, it takes the smear or biopsy under the microscope. This is the fast way to establish the diagnosis of invasive fusariosis. So this is the reason why we are here. We learn from our expert how to work together, take the biopsy and review under microscope. Then you know how to prescribe your medication. This global guideline suggests how to treat. The right-hand side, you can see the algorithm. The key issue is immediate treat, initial antifungal, surgical debridement, if possible. And emphasize the liposomal amphibia or voriconazole or combination, and the emphasize avoid slow escalation. Avoid slow escalation. This is common practice for conventional ampho. That means immediate achieve the high dose as soon as possible. However, in this global guideline, they emphasize that there are no randomized trials evaluate the efficacy of antifungal drug. However, the author, this guidelines suggest primary combination therapy with a potential step down to monotherapy later on if MIC of the azole and the protein become available. During the severity, take consideration of the severity of the disease. MIC and azole and the protein are often high, and sometimes difficulty in achieve voriconazole drug concentration within the target range in short period of time. Why need to combination therapy? This multi-center study demonstrates the very poor outcome. As I emphasize, very poor outcome using the deoxycholate amphotericin B. Alternative, if you use the voriconazole, liposomal amphotericin B, or combination, the 6-week death rate dropped to 1/3. Nevertheless, this study also emphasized, based on multivariate analysis, the persistent neutropenia was the only risk factor for death, regardless of antifungal agent. So, recommendation for management, not limited to the regimen. Also, the oscillatory therapy, including surgical intervention, GMCS granular transfusion. Also, you may take the advantage of the GM, if possible, at diagnosis. So in conclusion, we back to the element of the antifungal stewardship. Fusarium is real, but it emerged, become more important. Without the clinician alert, we cannot identify the outbreak. So every one of you play a very important role. Take the unique feature. If you see the hiding hyphae and the adventitious is-like sporulation together in the skin biopsy, in the high-risk patient with multiple skin lesion, you can presumptively diagnose of fusariosis, then initiate primary combination therapy. And the potential step down later on, if your mycology colleague can help you to rapid identification to species level, it might give you an idea what is the best possible step-down regimen. I will emphasize here why identification to species level is very important, because Fusarium resistant to multiple drugs, but variable intrinsic resistance may be varied by species. By species. So diagnosis is still the key. So this is my presentation. Still has 3 minutes. Thank you for your attention.